Hello everyone, we are back, your two favorite hosts, myself, Alex, and Papa Beko. What will we be talking about today?
Something very important, how to call a consult, a night before interns.
Okay. So, let's dive into how to call a consult, something that can be really intimidating, right?
Yeah, I mean, the very first time
you are the one going to pick the phone and call the consultant. What exactly are you going to tell the consultant? How do you convince the consultant to come see your patient? Let's see how it goes. Do you have a clinical scenario, a patient you want to present to demonstrate how the intern needs to call a consult?
In
Ghana, let me start from there. How are you calling the consult in Ghana at Confanoche if you want a consult?
I don't know. I don't remember because I didn't really work with Confanoche.
Do I remember calling consult at Confanoche during your housemanship?
I did not.
Okay.
Call a consult. I don't
I
remember.
mean, I did surgery. I was the neurosurgery house officer, and they will check the timetable to see who is on call, and then the house officer with the consultant, and everyone was looking for me because I was the neurosurgery house officer, and I didn't actually know what exactly we were doing. But if it was going to be an emergency, which in most cases is bare hole, we'll send the patient to theater and drill their hole. And that was it. It wasn't that scary. But let's see, how do we call a consult? And kindly demonstrate for us.
Let me give it a try. So I'll pick up the phone, and then usually here you call the operator, and the operator gives you whoever is on call, whoever is on duty. Could be the nursing practitioner.
Okay, so I'm the operator. Call the operator to connect you to the consultant or the specialist extension.
Yeah.
Okay, all right.
So I should call you?
Yeah, so I'm the operator.
Okay, so hello.
I'll be the operator and I'll be the consultant too. So.
Okay, all right. So, hello. I am Dr. Beko. Could you please put me through to whoever is on call for cardiology?
All right. Do you mind holding on?
Yeah.
Okay. All right, Dr. Beko. Cardiology team on call. It's on the line. You can go ahead.
All right. So, hello, Dr. Kumi. I am Dr. Beko. I am with Team B, Internal Medicine, and then Dr. Hafiz is my attending.
Do you want to say you are Dr. Beko to the specialist?
Well, usually there is a certain format you have to follow, but once you adopt your style, you can actually freestyle. So really, what I would say is that, hi, Dr. Kumi, this is Papa. I'm an internal medicine resident. I am with Team B and Dr. whoever is my attending.
So I want you to make it real for our listeners,
Okay.
our viewers. Then we go through maybe the template or whatever there is there to make it more formal. So go by it the informal way,
Okay.
or the way you have done it.
All right. So this is how I would have done it too. Hello, Dr. Kumi. This is Papa. I am an internal medicine resident, and I'm with Team B. Dr. whoever is my attending, and I have a consult for you. So I have a patient in 4312, Mr. AB, with who presented with chest pain and with a background of multiple cardiovascular risk factors, and he is end-stage status post-cabbage about 10 years ago.
Wait, what room number is the patient again?
4312.
4312. Can you give me the patient MRN number?
909-556-285.
Okay. And you said the patient is in which room again?
4312.
Okay, 4312. Is that patient AB?
Yeah, that's patient AB.
All right, go ahead.
So he is here for chest pain on the background of multiple cardiovascular risk factors and is status post-cabbage. End-stage status post-cabbage 10 years ago.
Any idea who did that cabbage?
Yeah, Dr. WA.
Is it with our system?
No, Northeast Georgia.
Okay, all right.
Right. He on EKG has some ischemic pattern dynamic changes, and then his high sensitive troponins greater than 99th percentile. So we are consulting you to help guide further management.
Okay, all right.
We have started him on aspirin and then carvedilol, and then we've put him on heparin drip.
And how is the patient doing?
Well, currently he is stable, vitals are holding steady, and then he is not tachycardic.
And the chest pain?
Still there.
He's still having chest pain?
Yes, still having chest pain.
Okay, better than it was?
Well, not really improved from when he came.
How urgent is this consult? Do you want us to come now?
Because we've started him on aspirin, beta blockers, and heparin, his chest pain is still not improving. I think it's pretty urgent, and we need a cardiac catheterization as he already has a history and has multiple risk factors.
All right, we'll come see the patient.
All right, thank you very much.
Okay. Yeah, so I put Beko on a hot seat there. I was the cardiologist for, was it 3 minutes?
Yeah.
Yeah, so I was a cardiologist for 3 minutes, asking Beko very relevant questions pertaining to his patients that he thinks I should do a cardiac cath for. Perhaps the patients eventually my assessment will not even be a good surgical candidate. So I insulted Beko in my head. Briefly. Anyway, so I'll go ahead and go through the formal process, which as an intern, you'll be asked to present or to follow in calling a consult, but sooner than later you realize that it gets easier, it gets better, and you freestyle like the way Beko did it, instead of following this format. But when you start, you want to at least have a framework in mind as to what you are doing, and that is where this format or this framework comes in handy. So permit us to go through this format, but with time you realize that Beko style is actually a more practical style that you end up doing. Everyone has their own way of going about it, having followed this framework and knowing the process of what relevant information there is to communicate to the specialist. And with time, you realize that you have become familiar with the specialist, knowing how they want to be consulted. Some of them even do not want you to call them over phone. They want you to send them a secure chat because they may be in the middle of a procedure whilst you are calling them and may disrupt the process or the flow. So they expect that you leave them an epic chat and someone see that chat and responds to it and or prompts them, and that's how it flows. So it depends on the individual, the consultant, and how they want things done. Some of them will let you speak with their nurse practitioners first before you get to them, because their nurse practitioners will evaluate and say that, okay, this is an urgent consult and we need to go see and tell our specialist or our boss, versus some of them will let you deal directly with them, whichever the case is. Sometimes your attending will see the urgency of the consult and say, hey, I'm calling this consult myself, I'm talking to the specialist myself, because sometimes when you're a resident and you are calling the consult, they know that you are a resident, they know that, okay, there is some time to buy, because if your attending is allowing you to call that consult, it means that there is some time that they can take to get to see their patient, versus if the specialist or the attending themselves are calling the specialist. So all those nuances are things that you will learn going forward when you start residency. So the framework that we usually follow, it's actually called the consult template. So the mnemonic is consult, so CONSULT. So the C actually stands for contacts, right? So let me see. Yeah, so the C stands for contact the consultant courteously. The O, orient. The N, narrow question. The S, story, so you are telling the patient story. The U stands for urgency, how urgent is a consult. The L, stand for later, we will explain. And the T, thank you. Did you thank me?
Yes, I did.
Okay, all right. So
I hope I did.
at the end of the day, I mean, say thank you to your consultant after calling the consult. Yeah, for some reason you need to thank the consultant or the specialist. So contact the consultant courteously. So under that, the caller's name, training level, the team, and Berku did justice. So he said, I'm Papa Berku, I'm a resident, I'm an intern with Team B, requesting a consult. Then he oriented me, the cardiologist, by giving me the patient's name, the medical record number, which is very relevant because once it's input in the electronic medical record, it sends you directly to the patient's room and everything, because once again, patients may have similar names and overlap of names, age, and all that at the same time or simultaneously. So the MRN is very important in getting to know who the patient is in terms of the patient room and floor. Then you are supposed to ask a narrow question, which in most instances, when you become very familiar, you realize that you end up not asking your consultant a question. But in every consult, there is a question you are asking as to whether you should go in this direction or that direction. And it's the job of the consultant to come and answer that question. So in this clinical scenario, the question will be, are we doing only medical treatment or we'll do cardiac catheterization for this patient? That is actually the question that is embedded in the consult that Beck will call. He didn't ask the consultant or the cardiologist directly as to whether, do you want us to go ahead with the medical management given that the chest pain is persistent and he may need cardiac catheterization, or you want us to wait for you so that you come and do cardiac cath? But the question is embedded in the consult. The story of the patient, people said this patient is so and so, female. Past medical history is in the story, the patient hospital calls and relevant labs. He mentioned the troponin, he mentioned the fact that the patient is already on heparin drip, we've already given the aspirin. Now, this is where it becomes important because of system-based staffs. In our setting, in our hospital, patient with NSTEMI, or even with STEMI, you do not want to go ahead and give the clopidogrel or whatever P2Y12 inhibitor you want to give, because if it requires a more invasive procedure like cabbage and all those stuff, then the patient will have to wait for, I think, 5 days before that can be done. Then you will actually delay management of the patient. So it is incumbent on the cardiologist to decide on whether they will give it or not, because they can anticipate whether the patient will have cabbage or not based on what is found on imaging and all that. So this begs the question that this is a very urgent, if not an immediate consult that they need to come and see and decide on and make those big decisions, because time to giving clopidogrel and all those stuff actually matters. So that leads to the U. So we've tackled the C, which is contact the consultant, the O, orient the patient, and narrow question, S, story. Then U, urgency. So that begs the fact that how urgent or immediate the consult is needs to be mentioned. If it's within the 5 minutes you want them to see, you say that I think this patient will benefit from being seen in the next 5 minutes, given that we are yet to decide on giving the patient clopidogrel or Plavix. Then later, if the consult is not so urgent, sometimes, there's a lot going on that the consultant may miss on seeing your patient. So you can make a follow-up plan with the consultant and give your pager number. That's okay. You can page me later on this pager number after you are done seeing, or if you have any clarifying questions. So make a follow-up plan with the consultant as to how and by when they can, or if they want you to call them back at a later time, you can get their pager number directly, and after all this, say thank you to them. So that's a consult. C for contact consultant courteously, O for orient, N for narrow a question, S for story, that's the patient history and all that you've done for the patient, U for the urgency of the consult, L for later, and T for thank you. So let's apply this consult mnemonic to your patient. So contact the consultant courteously. Did you consult me courteously? Do you think you have?
Yeah, I did. I think I did.
Okay. So I'll give you 60%. I think I don't feel respected. Right?
How's that? How's that stuff?
You should have a little tremor in your voice. Let me know that you are scared. Well, that's actually not the case. But sometimes, as an intern, when you start afresh, you are a bit intimidated because you are calling. And this is the reality. Some of the specialists are not so friendly. So, the seniors will let you know that some of the specialists are not friendly. And when you're about to call the consult, I think that needs to stop. Like, let's all go tabula rasa. Let's all go knowing that we are going to call a consult. We don't know who is who is friendly or not. So that, like, you decide, or through your own experience, decide who is friendly or not. Because the people who they said are not friendly, sometimes we end up calling them and they are so friendly, and you'll be like, so what happened? So you see, so I'm your friendly cardiologist consultant who will not intimidate you. So that's why you were so free and flow with me. So he contacted me courteously, which was okay. The O for orient, how did you orient me again?
Patient name.
Okay, so you gave me the MRI number, the full name, and then I was able to identify the patient bed number in the floor. Then narrow question. So you didn't go straight up to a narrow question, but at least I got the question you are trying to ask me, the consultant or the cardiologist from your consult, which was whether we are going the medical pathway or the surgical pathway. And like I already said, the story, the patient age, sex, pertinent history, hospital cost, relevant labs and radiology, you've already mentioned those. And then the anticipated plan is one thing that you may need to. So if you plan of, so you can say, we plan of keeping him on the heparin drip until you see him. We plan of, now that we have given the maybe sublingual nitroglycerin 2 times and it's not responded, we plan of giving a third one to see, because it's after the third one usually that we will say they are not responsive. So at least whatever you anticipate doing before they see the patient, you can say it, because that is when they will say, okay, hold on with what you are trying to do. Maybe stop the heparin, stop this, we'll send the patient right to this thing. So stop this and this and this. Okay, this is the point that although they said there is a demise of Mona, we don't give morphine as routinely as we used to. Okay, we are okay with you going ahead with maybe 2 milligrams of morphine if this doesn't respond, whilst we prepare to send the patient to the cath lab. So the anticipated plan is very important. Then the U for urgency, Beku was like, I need you guys. You know, he was being diplomatic, but in his head, he needs you guys to stop whatever you are doing and come and send my patient to the cath lab and then put a stent in there if needed. If you are fortunate, they'll come very immediately and say, oh, we even think this elevated troponin is demand ischemia, patient is anemic, he has CKD, there are other reasons why this troponin is high, we are not concerned, but keep this patient on heparin for 48 hours, and we'll follow. He will follow us up as an outpatient and all those stuff. Then you'll be like, okay, cardiology saw patients, recommend outpatient follow-up. We'll continue heparin for 48 hours. Appreciate cardiology recommendations. That's a language that you learn later. And then that sends me to the L component, which is the later in the consult mnemonic. That is when you establish a follow-up plan. I'll reach out by this pager number to follow up on your recommendation. So, like I said, patients, the consultant can say, do this and this for the patient, and let me know what the outcome is in 30 minutes. So you get the cardiologist extension or the cardiology NP's extension and say, okay, I'll follow up later. And these are for non-urgent consults usually. And then thank the consultant for their time and their assistance. For some reason, their time is so precious, and you need to thank them always for their time and assistance. Yeah.
Okay.
All right. I mean, you are just an intern. So. Yeah, so that is basically how you go about consult. You get used to it with time. It becomes very handy. When we can do it this way. So gastroenterology. What's the most common consult that we call for gastroenterology? What's the guess?
Liver cirrhosis with scoping.
Liver cirrhosis that they come with
lower GI bleed, upper GI bleed.
GI bleed. So variceal bleed, they are coming with upper GI bleed, which is which requires their immediate attention more often than even the lower GI bleed.
Yeah.
So you end up consulting GI or gastroenterology more often for GI bleed. So then you want to, and it's urgent, but the fact of the matter is that they will say that you need to stabilize the patient, admit the patient to the ICU, and then within 24 hours, they will scope the patient. So once you mention GI bleed, they know what to expect. So they expect you to let them know that this patient has already been admitted to ICU. You have your 2 IV ball cannulae, you have octreotide because it is variceal bleed, and so proving otherwise if the patient has liver cirrhosis. You already started the patient on the PPIs or proton pump inhibitors. You must do what's the basic stuff as the internist for the patient, and then ask them start your ceftriaxone prophylaxis and all those stuff. Before you ask them that, when do you want to scope these patients, or ask them whether they want to scope these patients or not, which will be the question, and give them a feedback as to how the patient is doing. If the patient is deteriorating, it's your job to call them back that, hey, the patient is not doing so well. They wouldn't really do much in terms of scoping, but at least they will give you some recommendation, and you are the one coordinating the care of the patient. And trust me, this same patient, you may end up consulting cardiology for that same patient. You may end up consulting nephrology because that patient will have hepatorenal syndrome. That same patient will have a heart failure with, or may have atrial fibrillation with ARIA because has lost so much blood, became dehydrated, or has third space, became dehydrated, and that triggered rapid ventricular response from the atrial fibrillation. So you have a lot of consultants on board, and because you are coordinating the care of the patient, there are times that cardiology and nephrology, in terms of diuresis and fluid balance, will have conflicting recommendations, and you have to clarify from each of the consultants that, hey, cardiology recommended this, but you said this. What do we settle on? It's being an internist is not an easy job.
Yeah, it's like a lot of coordination.
You are actually the one, we call it the primary team. You are the primary team of the patient. It means you are responsible for the patient. The consultants are only coming with their recommendation, and actually You are the one to decide that, okay, this recommendation you are bringing on board is okay with me. I mean, that's not what we do, but you have the right to say that, okay, you're advocating for the patient that, hey, I'm not okay with this recommendation because of this and this. Do you mind reviewing your recommendation or this? Because sometimes they are not, they do not have access to some of the information that should help with their decision making. They are giving the recommendation based on the information you give them, and sometimes digging back into the charts to find out if there's any contraindication to maybe certain medications that they recommend or not lies on you, the intern, to do that chart review, the senior resident to do that chart review, and then inform your attending about it. And so we are actually the detectives of the team, right?
Yeah.
We do the digging, and sometimes you are proud of yourself if you go and pull out something that everyone has missed and it's done 5 years ago, until you meet one of our attendants who is a master of pre-charting and will bring all the information related to the patient and prove to you that yes, he or she has been doing this several years before you were born.
Oh yeah.
Yeah, so I mean, that is basically how to call consult. Very concise. Berko has summarized it nicely. Use a consult mnemonic, and once you become very familiar with the concept of consult, you become a second nature of you, and you will not tremble like Berko did when he was calling consult for the first time. All right, okay. Kindly go ahead and subscribe. We intend to share more insight, more videos, and more practical things that we wish we know from the very first day when we started residency, because we don't want you to go through that stressful process, that overwhelming and intimidating process when you start residency as an international medical graduate. So until we meet in our next and subsequent videos, have a good time.